Good afternoon. I'm Congressman Steny Hoyer of Maryland's 5th District and the Majority Leader of the U.S. House of Representatives. I'm sorry that I couldn't be with you in person today for the American Epilepsy Society's annual meeting, but know that I am with you in spirit and in solidarity with the critically important work you're doing to advance research into treatments and a cure. Epilepsy can impact anyone, anytime. I understand that fact well because my late wife, Judith, lived with epilepsy. Millions of Americans face that challenge, and the American Epilepsy Society's annual meeting is so critical because it brings together epilepsy professionals from academia, clinical practice, industry, and advocacy from across the country and around the world to exchange information and new ideas that will help advance cutting-edge research. Every American family that faces epilepsy has something at stake here today. They, as I am, are inspired by the collection of talent and drive and intellect gathered in Baltimore to address the challenges of this disorder. I want to make particular mention of the Epilepsy Leadership Council, a coalition of more than 30 professional societies, patient advocacy organizations, and government agencies that understand the value of collaboration in meeting these challenges. Before I introduce this year's keynote speaker for the annual Judith Hoyer Lecture in Epilepsy, I would like to thank Dr. Walter Koroshetz for his leadership at the National Institutes of Neurological Disorders and Stroke. With Dr. Koroshetz's expertise and vision, NINDS is focusing on efforts like the Brain Initiative, which is revolutionizing our understanding of the human brain, and the Epilepsy Centers Without Walls program, which has brought multidisciplinary teams of scientists together to solve challenging problems in innovative ways. Here in Congress, I am proud to be a strong supporter of medical research and programs and services that support Americans with epilepsy and seizures. As we continue to work on funding the government and preventing a shutdown, both the House and the Senate have recommended a significant increase for the National Institutes of Health and for the Center for Disease Control's epilepsy program. We are in an unprecedented place of scientific understanding when it comes to epilepsy, and we need to do everything we can to keep this momentum going and seize every opportunity. Leaders like today's keynote speaker, Dr. Eli Mizrahi, give me hope. Dr. Mizrahi is chair of the Department of Neurology, as well as a professor of neurology and pediatrics, holding the James A. Quigley Endowed Chair in Pediatric Neurology at Baylor College of Medicine. He is also chief of the Neurophysiology section at the Neuroscience Service line at Baylor St. Luke's Medical Center. He is past president of the American Epilepsy Society and has received the AES Clinical Research Award for his work on neonatal seizures. Today, he will discuss recent advances in clinical care of newborn infants suspected of seizures, including revised classifications, the application of EEG video monitoring, and the expanding role of genetic testing. My wife, Judy, would be very proud of the progress that has been made, and so glad that all of you are here today, committed to advancing this critical work. I will continue working to promote and support your efforts on Capitol Hill, and I hope today's lecture will spark new ideas and new areas for innovative collaboration. Thank you all for what you do daily to make the health of our people better and more secure. God bless you.
Well, good evening. It's a great pleasure to be here and to give this 17th Judith Hoyer lecture. I greatly appreciate the opportunity to do this and also for this wonderful introduction. I'm going to be talking about the advances in the development in the diagnosis and management of neonatal seizures. And as I do, I'd like to emphasize the importance of collaboration within our own community, internationally and nationally, as well as the efforts that have been made with patient organizations to understand more fully the importance of this disorder. Just as a brief reminder, I do have some royalties from publishing and then also some consulting relationships. And also I'm part of the International League Against Epilepsy Task Force in Neonatal Seizures, and I'll be talking about that some more in a little bit. Also, I need to remind everybody that we'll be talking about anti-epileptic drugs, and these are considered for neonates off-label and not considered approved for their use in this age group, which is, of course, an enormous problem for us, for those of us who take care of children of many ages. The Judith Hoyer Lecture was established through, as we've heard, through a collaboration between the US Congress, the National Institutes of Health, the Epilepsy Foundation, CURE, and the American Epilepsy Society. The idea is for us to summarize progress and stimulate further research that will lead to meaningful improvement in the lives of those with epilepsy. This lecture is designed to be accessible to the public through live streaming and, as you've heard, through video archiving, and for us to further educate the community and also to further engage the community. As we'll learn, there's a lot at stake for those who are interested in epilepsy through their children and through their families. Judith Hoyer, as we heard, was a member of the board of directors of the Epilepsy Foundation. She herself had epilepsy and became an advocate for people with epilepsy and their families, and a champion for research towards a cure for a better understanding and quality of life of those with the disorder. Here she is with younger Steny Hoyer on the steps of the state legislature here in Maryland as he began his political career. Above all, she was an early childhood educator. She was active in her career as an educator in the classroom, as a developer of multisensory curriculum for kindergarten, first and second graders. And she was a pioneer of the two-generation learner strategy, bringing both children and parents into the classroom to help develop individualized strategies for how these groups could learn. She was also an administrator of early education programs in Maryland, and at the time of her death, she was the coordinating supervisor of early childhood education for public schools in Prince George's County here in Maryland. And during that time, she created a central educational facility to coordinate early childhood services and to foster the cooperation of governmental and private agencies around the need of local families. And so based upon that specific effort, following her death, Congressman Hoyer and then Governor Glendening led a movement to bring that model to other areas of Maryland, and they became known as the Judy Centers. So in 2000, the legislature enacted the Judith Hoyer Early Child Care Education Program. 13 centers were established as hubs, named the Judy Centers, and over the next several years, over another 43 were established, so that there are about 56 now that are around the state. And here's a photo of the congressman dedicating one of these centers, this one at Andrews Air Force Base. But this is where we come in, and this is the intersection of Mr. Hoyer's interest in early childhood development, and then what our interests are in terms of neonatal seizures. Because everything we do in terms of taking care of these infants is to get them to be good learners, to work well in school, and then to move on to through a productive life. This is a construct looking at some of the outcomes of neonatal seizures with encephalopathy. And we'll see that this was from Chevelle and Garfunkel's study that I'll comment on later. You see the reference down below. And the idea is for us is to understand more fully what the precursors are to these developmental issues. So is it the underlying etiology? Is it the overlapping anti-seizure medications that some of these patients get? Is it the seizure burden that they have that then lead us to this triad of developmental issues? And then, of course, what happens to them afterwards? And where do they come when they get to school and beyond in terms of learning, behavior, and the quality of their life? I'm going to be talking about these specific issues, and this is not meant to be a comprehensive review, but really to talk about some highlights of some of these individual issues. But at the same time, I also want to talk about some other issues that come up in addition to the details of understanding neonatal seizures, and that is issues relating to healthcare disparity. Earlier this year in August in Pediatrics, the journal, there was an editorial and then also a review article about disparities in the neonatal intensive care units. And one of the interesting quotes was that for many, it's been assumed that care in the NICU is consistently of high quality and delivered equitably. Researchers challenged the long-held assumption that NICU care is the great equalizer for improving infant health. And for the most part, we think that that's true. And my point as we continue to learn more about these advances is that we have a real challenge in terms of being certain about how we distribute and be certain that these are brought to infants in an equitable way. So that as we think about these issues, that the advances that we're going to be talking about are characterized by technology, by a drive to evidence-based medicine, and a refinement of the understanding of outcome determinants. So our task and a real challenge is to be certain as we develop these advances that we create them in a form in which all neonates can be in some way be advantaged. And we'll discuss that issue also. So as a clinical problem, as we know and are concerned that seizure hazard is for the most part greatest in the neonatal period and can be the first and perhaps the only indicator of central nervous system disorder in the neonate. The greatest occurrence within the first few weeks of life, and then as we're going to be thinking about it, we're really going to be thinking about brain age rather than chronologic age. And that neonatal seizures are associated with detrimental effects on childhood neurodevelopment with up to 50% in serious adverse sequelae. So this is still an important issue for us. This is an older graph from Lanska from the 90s, but still holds true that we see most of our neonatal seizures very early in life. And they occur within 1 to 3.5 per 1,000 live births, about 1.5% prevalence, and that they vary, their occurrence varies according to risk factors, either antenatal or intrapartum, according to birth weight or gestational age. The other issue that we often don't really discuss is the impact of infants having seizures on the families. And this is an interesting study by Hill et al. Looking at seizures and anti-seizure medications and their impact on the families. So in a large questionnaire, many parents responded to the survey and answered questions related to their baby's care. What worried you most about your baby's seizures? Well, it was brain damage, continued seizures, cardiorespiratory implications, causes of seizures, and the uncertainty about what was happening to your child. What worried you most about the treatment of your baby's seizures? Short-term and long-term or unspecified adverse outcomes? Therapeutic failure, what happens if these drugs don't work? Uncertainty about the nature of medications and choices that there might be, including alternative therapies. And then when can my baby come off of anti-seizure medicines? What would you like the doctors to know? Well, that there's an emotional impact on the treatment of these babies, that the families are concerned about adverse effects, and that they would want more, not less information, and the importance of good communication. And what are the most important questions you would like researchers to answer? Long-term impact of medications, of seizures, and the effectiveness of medications themselves. So we're all thinking about the same things. Often we don't know that because there's less communication than might be ideal. But neonates are, as we said, at risk to develop seizures, and there are different ways to look at that, either age-dependent epileptogenesis, or the period of rapid brain growth and development, or the unique concentration of potential for CNS injury in the neonatal period. So there are different ways then to consider epileptogenesis, and we all know this graph, and it's now over close to 10 years old, which really looks at the relative changes in excitation and inhibition at a synaptic level over the short period of time within the neonatal period. Another way to look at it is to look at anatomic or gross brain development, and the arrows that I showed below is really the age at which, the gestational age at which we're going to be thinking about neonatal seizures, from around 25 weeks up through full term. And yet a different way to look at it is also to look at the functional changes that happen over that short period of time. This is the EEG of a 27-weeker, which is discontinuity and not much else on the EEG. But then just a few weeks later, at 30 to 32 weeks, there is more continuity, some asynchrony, some beta-delta complexes, some theta bursts, and it starts to become a much more enriched electrographic environment. Even later on, 36 weeks, there are some so-called frontal sharp transients as part of these grapho elements that we see in development. And then, of course, at term, we see a continuous EEG with polyfrequency without the prematurity benchmarks that we might see in the EEG that really shows us a full evolution of EEG and correlating with the anatomy, the anatomic growth. The issues about semiology and classification have been, for the most part, dominating discussion about neonatal seizures since the 1950s. And the concepts that were current at each particular era really are based upon the technologies that were used at the time to understand that. So they were initially related to clinical observation, or just EEG, or EEG video studies, or then prolonged monitoring studies. But much of that, and we're going to talk about what had happened in the past, but much of this is now being addressed with the ILE classification task force and a challenge to the idea that neonatal seizures are truly unique compared to seizures at other times of life. Just as an overview, early studies were just clinical observation only, and we learned a great deal about neonatal seizures from that period. That they could be asynchronous on the two sides, they're predominantly focal, they're not generalized tonic-clonic, and they were really talented investigators who looked hard at the bedside to get us started on understanding this disorder. There were clinical observations with interictal EEG, And then we started seeing clinical observations with EEG, ictal EEG, and I'll mention some of those studies. Eventually, in the 60s, the French started talking about EEG and cinematography, and eventually EEG video and then prolonged video monitoring. In the 70s, there was this discussion initially by Joe Volpe about describing the unique patterns of neonatal seizures and describing a so-called subtle seizure type, which was more diffuse and then had some pedaling and rowing movements and then also some chewing and lip smacking movements. There were similar classifications by others, but this is the classification that for many years held as part of our bread and butter diagnostic armamentarium. Watanabe did a really groundbreaking study in the 70s looking at clinical EEG and clinical seizures and ictal EEG. And so he looked at the motor features that we had come to know, but then also started looking at some of these limb and body movements, the oral movements, ocular signs, respiratory changes that have now come into our awareness of the neonatal seizures. In the 80s, Dr. Kellaway and I did some EEG video monitoring studies. And I show you this picture just to show you what we would bring up to the bedside. And now, as you know, we have basically a laptop and a web camera, and I have a much more compact way of looking at this, and also with digital recordings. But we characterized events and developed some clinical correlations, and then describe decoupling, which is now more, the term is uncoupling, which I'll talk to you about in a minute. So we then started looking at the electroclinical seizures, the clinical-only seizures, and the electrographic-only seizures, which represented in our first cohort about 30%. At the time, we were unwilling to discard as seizures of epileptic origin, the clinical only, without further investigation. There was, interestingly, some pushback at that time, but as we'll talk about, now the so-called clinical only seizures, or the events without electrographic seizures, are classified in a different way. So overall, others then began to look at these issues in greater detail. And then we started learning more about how good we were with diagnosis. So this is a study from the group in Cork, and the real issue here is that after they looked at EEG videos and they showed them to observers, that it was difficult to accurately clinically differentiate between epileptic and non-epileptic events, that there was the inter-observer agreement was limited, and that it was with either physicians or healthcare providers. And so their point was that until reliable, continuous neurological monitoring is available, some babies with seizures will remain undetected, and others with non-seizure movements will continue to be treated. So as we mentioned earlier, that the study of neonatal seizures is really a collaborative effort. And we've been meeting and discussing various issues based upon the technology at the time. And this is a meeting in Vancouver in the 90s. And as you can see here, this included Watanabe and Perrine Plouin, and of course, Fred Anderman and Fritz Dreyfus and Charlotte Dravet. Here's Barry Tharp and Mark Scheer and Olivier Dulac and Ilo Lepik. Natalio Fedreman and Olivman, and Federico Vigevano. And so people have been thinking about this and been talking about this international collaboration to get a better understanding of these issues for a long time. The most recent effort was began in 2017 when a task force was seated to have a review of the classification semiology. At that time, you can see the members, and Ronit Pressler is the chair. So this harkens back to the construct of the 2017 classification of seizures and epilepsies for older children and adults. And the challenge was, can this construct work for neonatal seizures? And so we began to look at that and began with this construct of we started out with all events, with or without EEG correlate, are seizures, and that we were dividing them into epileptic and non-epileptic origin, but then move them up and to the side, so that it's only those with EEG correlate have been more of a focus. We then emphasized the electrographic seizures, and then the electroclinical seizures were either motor or non-motor, to create our seizure types of motor, non-motor, and electrographic for this framework, and then put it into this larger framework of comorbidities, the epilepsy syndrome, and then the etiologic factors. So that our construct is about the same, but there still is a relatively unique aspect to the neonatal seizure category. The other issue is that we began to shift how we began to make that diagnosis. So you can see that the EEG video monitoring becomes central. And so that once seizures are captured, they're categorized into either EEG with clinical signs or without, and then we also then added a sequential category, which then allows us to have different seizure types or a progression of different seizures within the group. But EEG video monitoring now has become a critical aspect of this classification. So on the one hand, we're better defining our events. We can quantify seizure burden. We have a precise method of determining efficacy of treatment, and we have some uniform criteria for studies. But on the other hand, our infants without access to EEG may be relatively disadvantaged. And from a clinical perspective, that seizure surveillance transitions from clinical observation to long-term monitoring. So rather than having nurses and health professionals watching the babies to look for seizure onset, we really then are beginning to look for at-risk babies and starting prolonged EEG video monitoring to see how well we do with capturing those events. Neurophysiology then becomes an important part of what we do. This is our armamentarium of what we can do: routine EEG, prolonged bedside EEG, amplitude integrated EEG, and then EEG video bedside monitoring. Each have their positive aspects and then their limitations. The limitations of prolonged monitoring are that it's very labor intensive, and that in order for it to be successful, there needs to be real-time interaction between the bedside and the physician interpreters and the people taking care of these babies in order for this to work as it should. In the mix, of course, is the American Clinical Neurophysiology Society, and have been discussing the definition of electrographic seizures, since now that is key to what we need to understand. And it's the repetitive and evolving pattern which has been a focus of attention. So this is really what they look like. So it's sort of an onset, and then a continuation with varying changes in morphology, and then even more so with this sort of tailing end of a seizure, which is a continuous tracing. And this is an example of different types of electrographic seizures. And you can see that some start focally and remain that way. Others then start in one location and migrate across to the other side. There are morphologies that are high amplitude and rhythmic. And this, while it looks generalized, is not. It's multifocal, asynchronous on the two sides. And then there are also these special patterns, the so-called alpha seizure discharges, and then also the seizure discharges of the depressed brain. So there's a wide range of types of electrographic events we need to look at. But the other issue is the duration of the seizure. So we've always then discussed it as a duration of 10 seconds, of at least 10 seconds, but that has become more recently challenged and also now becomes important for us as we're thinking about seizure surveillance. So look at this discharge here, which is about 6 seconds long. And so the question is, do you call it a seizure, electrographic seizure, and launch the evaluation and consideration of that baby? Or do you wait for them to be much longer? The task force then, there have been some investigators that have looked at this in some other ways and have described these brief bursts as brief runs of rhythmic discharges or brief ictal rhythmic discharges or some other variations, so-called all in the falling into the category of the rubric birds. And so that's become an important feature. So for example, here from one of these papers is a brief run that then looks exactly like the onset of the more prolonged run, which was actually called a seizure. So this represents something that we need to look at in more detail. So the evolving discussion then about seizure duration was addressed by our task force. And the question of, should we be thinking about no minimum duration, but only an evolution in frequency and morphology of the discharge? And that's where that discussion is now, that we really want to focus more on the evolution of the discharge. It can be brief, but it's the evolution that really defines it as a electrographic seizure. Just a few quick words about epileptic syndromes, because they're all based within our clinical and electrographic categorization. Traditionally, as you know, we had this group of benign neonatal convulsions, the familial neonatal convulsions, and then the encephalopathies. But then with the new classification, we are now to three three syndromes of benign familial neonatal epilepsy, early myoclonic epilepsy, most often associated with Aicardi and Gutierrez, and then early infantile epileptic encephalopathies of Odahara. In addition, over time, we've also learned about clinical variations of KCNQ2 mutation, which is something that we had always had early on considered to be associated with benign familial neonatal convulsions, but really in the end also was associated with epileptic encephalopathies, which were considered to be a variation of Odahara syndrome. So we need to start thinking about those in terms of our syndromes as well. One other point is that this little scale here sort of suggests that it's a binary feature, but as we'll learn, it's really not. So just to consider the epileptic syndromes, and just to make a point, some of them still have a clinical component that's important. The early myoclonic, the erratic myoclonus for the Aicardi group, or the tonic spasms for the Odahara group, and without very little specifics about the KCNQ2 encephalopathies. The EEG features, it's important that suppression bursts can be seen throughout, and that the etiologies, as we're going to see in a little bit more detail, have been shifted more to genetic issues, which have now become, as you know, much more of an important feature of of our etiologies. Treatment options still for many of these babies are limited, except for the KCNQ2 babies, which now have now become channel targeted and disease modifying. So just a few words about etiology. And the idea is that as we think about etiology, that it can be the ultimate determinant of long-term outcome. So it's key to identify seizures, but now we're in a situation where many seizures are electrographic only. So our goal is to look for etiologic-specific therapy and then start thinking about anti-epileptic drugs. There are long lists of acute etiologies of neonatal seizures. Most of them are going to be acute neonatal encephalopathy from the acute categories. And here's just an example of a baby with a brain hemorrhage and a focal seizure onset, or a focal infarct in the left frontal region with a seizure discharge. So these still do occur and are important parts of the landscape of neonatal seizures. But overall, in terms of the chronic etiologies, the genetic conditions really represent an important factor for us. This is a figure created by Ronit Pressler and the group to look at the relative importance of varying etiologic factors, and HIE still is an important feature, although the genetic factors still represent a larger group. There have been some recent studies just looking at screening babies for genetic findings when they're otherwise undiagnosed. And even though there are variable numbers, the numbers are relatively high, 29%, 61% with larger screens, looking at babies with EME or the Ohtahara's babies. And even then, when you look at more focused screenings, and this is from Shellhouse and her group, is that looking and focused at epileptic encephalopathies or brain malformations or clinical benign familial epilepsies, the hit rates are still very high. So just to emphasize, our traditional reported etiologies for the EME have always tended to be towards metabolic, and for the Ohtahara's have always been towards the anatomic with congenital anomalies. But genetics have become an important part of EME, and then also for the Ohtahara babies here, with about half of the reported cases, these three genetic abnormalities here. So this represents an important shift in terms of how we're thinking about these babies. I mentioned this before, and the scale really isn't a good way to look at this. This is a figure provided by Ed Cooper over at Baylor to look at the phenotypic heterogeneity of KCNQ2, with the idea that the channel itself is more complex with greater degrees of mutations, and that at the one end there can be loss of function, to the other end gain of function, and within that correlated to different kinds of neonatal issues, most notably for us, neonatal epileptic encephalopathies. So there's a lot to be learned, and a strategy of curating more of these babies to study them in a more detailed way. That's being done by this group, which was based in Ed's lab, Cooper's lab, the Ricky Project, which looks at and collects babies from around the world, looking specifically for their clinical characteristics and studying them further. The other issue, it leads us to disease-modifying therapy, and this now older paper, looking at channel openers for the KCNQ2 babies. And it's just yet a different way for us to start thinking about how to treat these babies and how genetics, the genetic wherewithal can put us in that direction. But let's just talk about other treatment strategies for a minute, and remember that etiologic-specific therapy is our mainstay. If you can't treat the underlying disorder, it's going to be very hard to treat the actual seizure itself. But we're really sort of in a quandary in terms of anti-seizure therapy and neonatal seizures, because our efficacy data is limited by a lack of defining randomized control studies. The therapeutic choices are informed either by people's experiences or studies without current diagnostic criteria. Medications are selected because of some presumed safety superiority. We have variable endpoints of therapy, and we don't have very many options if all options fail. So this is the results of a survey done by the San Francisco group in 2012, asking physicians what their choices were for anti-seizure drugs in neonates. And for both preterm and full terms, phenobarbital was the first-line drug. And then the benzodiazepines were important. We're seeing some of those become more popular, and we're also starting to see levetiracetam becoming it's supplanting phenobarbital in some centers as first line. But in a most recent study, just 2019 in Epilepsy, the Neonatal Seizure Registry group looked at a cohort of 534 neonates with acute symptomatic seizures. 66% had incomplete response to the initial loading dose of anti-seizure medicines, regardless of the medicine that was selected, and independent of gestational age, sex, or medication, or the dose. So there's a lot of work to do in terms of how we're going to treat these babies. So levetiracetam has enjoyed a wave of popularity and has been studied at several centers. Here's an example of 3 of them, and as you can see in the tables that there is some positive news in terms of in terms of some improved seizure control, but methodology limits us from grading these and having them be definitive studies. This is a study from Rao and Sankar from 2018. The blue line is levetiracetam, the red line is phenobarbital, and here, in comparing these 2 groups, the levetiracetam predicted a shorter interval to seizure freedom than phenobarbital. But these babies were selected for each of their groups based upon physician discretion. So here there were some limitations in design, but still encouraging. On the other hand, a very recent study looked at levetiracetam in premature infants and found that 74% did not respond. So there's much to learn about this drug as we think about neonates. We've also are learning and getting ready to find out about this randomized controlled trial of levetiracetam and phenobarbital, the so-called NeoLev-2. This is just some methodology that was published in anticipation, because the study will have video monitoring as a benchmark for both diagnosis and endpoint therapy. Another way to look at therapy is to look at and develop guidelines grading the quality of the data. And this is one way in which we did it, published in 2011. So there's a big lag between then and now, through the International League Against Epilepsy. And now there's a new task force, different than the classification one, that Ronit Pressler and Hans Hartmann are co-chairing, and that will be meeting at this meeting to do an evidence-based review for us to have a better understanding of the literature, what's out there in our modern standards. Neurophysiology, as I mentioned, represents an important aspect of what we're thinking about. And what really happens is there's been now a shift from clinical observation to electrographic surveillance. And here the idea is to, with a focus on minimizing so-called seizure burden. And the seizure burden then is the ongoing electrographic event with a presumption that that is not good for the baby's brain. Here are two EEGs, which look a little identical. The one below is a little subdued. The one on top is an electrographic event in association with a clinical seizure. The baby was treated with phenobarbital. The clinical seizure was controlled, but the electrographic event, as you see, returned in much the same morphology. So in '87, we had used the term decoupled for that. It seems that now it's more, the wider use is uncoupling of the clinical from the electrographic event, and it represents an important feature for us as we start thinking about how we're going to treat and what our endpoint is going to be. The American Clinical Neurophysiology Society has also been involved in these discussions and talking about the concept of seizure burden in terms of the number of seizures or the percent of time that seizures appear or how many regions of the brain they're involved with. So the strategy then is to look for at-risk babies, then to identify babies with brain injury or those who were clinically suspected or those, of course, who were medically paralyzed, and then also to be certain about recording them during weaning off of anti-epileptic drugs, anti-seizure drugs, and then also for some babies with suppression burst patterns on EEG to start with. Here are three panels of a baby that we recorded at Texas Children's, day one on hypothermia for hypoxic ischemic encephalopathy with a very depressed EEG. The baby on day three, as per protocol, began to be rewarmed. During those 3 days, no electrographic seizures. But as you can see in the bottom panel, we see an onset of an electrographic seizure, which would have been missed without seizure recording. This is taken from one of Geraldine Boylan's papers. And these are individual babies, and that are all being monitored. The black hash mark is when a seizure occurred. And the point is that in monitoring, seizure onset and recurrence can be unpredictable. So we really need to learn more about what's happening during monitoring and get a better idea about how to pace ourselves in terms of treating these babies. So the question is, how well do we do? And this is from Glass and her group, monitoring about 400 babies, and about 25% of them had electrographic seizures. And of those 25%, about 25% had subclinical electrographic seizures. So there is a significant acquiring of electrographic events with at-risk recordings of seizures, of EEG. Now the question is, how well do we do with the data we have? Well, Renee and Linda DeVries looked at that, and they looked at a group that they monitored and found that 27 of their babies with no electrographic seizures received anti-epileptic drugs, and 7 with electrographic seizures did not receive any drugs. So we have a lot to do in terms of applying these new protocols to be certain about real-time evaluation and interactions at the bedside. So let's finish up and just talk a little bit about prognosis. And so this is this construct from Garfunkel and Chevelle with to emphasize that it's not only just one thing that may happen to these infants, and that it's a combination of motor, epilepsy, and global developmental delays. A larger group was reviewed by Pisani and Boylan, and that there was about 18% with epilepsy, and then a very large percent with neurological impairments. There's been a discussion about how to score this, and the scoring aspect is not as important as the understanding that outcome is really multifactorial. And so we're going to see that prematurity is a risk factor for a poor outcome, as well as the severity and the timing of the pathologic process. This is a way of looking at it, and you can see the bar graphs that the premature babies have a higher incidence of epilepsy, mental retardation, and cerebral palsy, with the extremely low birth weight babies not doing as well as others. And this is a different way of looking at it. If you look at the top line in terms of outcome, the global hypoxic ischemic injury babies, the HIE babies, had higher poor outcomes. But if you looked at just focal or stroke hypoxic ischemia, they had favorable outcomes because of the degree and distribution of brain injury. And the same issue comes up with seizure control and outcome. And if you look at bar B, that the babies who did not achieve seizure control, in that group, there was a higher degree of death in that group. So it brings us to the issue of the impact of seizure burden, and that Shellhouse and Westhoff and Glass and the Neonatal Seizure Registry study group looked at that with the idea that seizure burden becomes an important factor in terms of outcome. And Nicholas Aben and his group also looked at that, but the high exposure to electrographic seizures was an independent predictor of abnormal motor development and abnormal language and abnormal MRI. So let's just end up here in talking about epilepsy for a minute and post-neonatal epilepsy. So this is a table of old studies and then one or two newer studies. So first, a comment about looking at old studies. These studies were done at a time that predated hypothermia for the treatment of hypoxic ischemic encephalopathy. So it's going to be shifted to an outcome that might have been avoided if that therapy was available. So we have to look at that information in a new light. But even later data looks at epilepsy at about, well, here 17%, we've seen it at 18 or around 20%. And it represents an important issue for us because it's not only whether you have epilepsy or not coming out of the neonatal period, but this, and looking at this from 2003, is a figure from Odahara, looking at the transition of epilepsy and the type of epilepsy that babies might experience if they begin, for example, with Odahara and then begin to transition to other age-dependent epileptic encephalopathies. So where are we? We have a clinical recognition that is becoming less of the basis for diagnosis and management, and that we have to start considering at-risk populations. There are variability of clinical manifestations. We do have inter-observer disagreements when we do see clinical events, and clinical electrographic events represent a significant portion of seizure occurrence. EEG video monitoring has really emerged as an important strategy for us, but it's labor intensive, and it becomes an important issue not only to offer EEG video monitoring, but how to manage it within a program, and to be certain that the data you're collecting has usefulness at the bedside at that moment it's collected. And that routine EEG may continue to have an important role. It needs to be focused, and we need to understand why we're doing the study and what kind of information we can get out of it. Genetic factors become even more so an issue, and we're going to be seeing that more during the study. We have a lot to do in terms of understanding how anti-epileptic drugs work and how good they'll be for our patients. And that outcome appears to be primarily determined by etiology, but we need to start having a better understanding about both how seizure burden and how the medications we give impact outcome. I also do want to mention, as we finish up, the Epilepsy Leadership Council, and to say that some of the work that I've discussed here have been supported by some of the members of the ELC. These are large organizations and these are small organizations. And some of these organizations started with a parent, a sick child, a telephone, and a kitchen table.
And these are the kinds of organizations that really can bring both parents, patients, and resources to the work that we do. So with that, let me acknowledge and thank the members of our group at Baylor College of Medicine and at Texas Children's Hospital, to the task force headed by Ronit and her group, and of course to the sponsors of the Judith P. Hoyer Lecture in Epilepsy. Thank you all for your attention and have a great meeting. Thank you.